doesn't sound very big God, but so many surgeons are very much interested in surgery and can sometimes lose perspective of what else they can offer. So thank you very much for coming.
Absolute pleasure. Absolute pleasure. I was absolutely delighted to get the invitation, Ruth, and your invitation started out with a few key words that very much start to whet my appetite. You probably can't see it from the back, but Ruth's written non-specific low back pain. She's highlighted that it's a very common presentation. She's said that it's challenging, and she wants it to be interactive. So we're going to definitely make it interactive. I've brought a few little props here. But going on from Ruth's little survey, impromptu survey, Adrian, I think you said you were the most confident manager. We'll pick on Adrian then. We'll pick on Adrian. So Adrian, if you see a patient with low back pain, there's no red flags, there's no neurological concerns when you see them walk in, but they're probably looking for a prescription because the usual over-the-counter stuff is not strong enough. They want to keep going to work. They're not sort of overly elderly, in the really productive ages of their life. What's going through your mind? You may have even done a CT scan already, something that sort of excludes occult sinister pathology. What's going through your mind as to what is causing your patient's symptoms?
Well, I guess just taking a step back, I'm sort of having a broad look at the patient as they come in. How old are they? What are their comorbidities? What's their mobility like? What's their body habitus? All of these things, and just I guess in the back of my mind, mechanical kind of low back pain affects 50% of adults. So it's just incredibly common, and so possibly, yes, we've got to think about other pathology and more concerning symptoms and ruling those things out, but potentially the likelihood is this is something's going to be managed pretty conservatively, and in the longer term things like fitness and strength training, weight loss and all those things may be part of the plan as well, but importantly just ruling out red flags and making sure it gets things like that.
When it comes to most other conditions, say someone comes to you with shortness of breath, have you got a much narrower repertoire of conditions that are go-to causations for someone with shortness of breath?
Not necessarily shortness of breath, probably respiratory or cardiac or anxiety, or that's still potentially. I get your point that some things that there would be.
I was just I start off with that because almost every patient that I see who has low back pain, one of the very early questions in my history taking is, has anyone told you what's causing your low back pain? And invariably the answer is no. Like, I've had back pain for 5 years, 10 years, chronic, and I've had multiple engagements with my GP, I've had multiple engagements with physical rehab, pain doctors, and they really don't know what's causing their back pain. They will say things like it's a bulging disc, or it's because I'm old, or it's because I'm overweight, or it's because I've got a sedentary job, or it's because I've got an overactive job, or my core is not strong enough. But really all of those things are associations. They are not causations, because I could see someone who's very old and they have back pain, and then the next patient that I see is very young. Or I could see someone who's very slim and they have back pain, and the next patient I see is very overweight. Or I could see an office worker who does nothing, and then I'll see a labourer, and they both have back pain. So it's very clear to me that we, as a industry, in terms of back pain, easily confuse association for causation, and that's kind of one of the biggest mistakes in medicine. That's what leads us up the wrong path when we're trying to manage conditions effectively. So this kind of dawned on me about 10 to 15 years ago. I started becoming really excited by back pain, And traditionally, as Reeve said, surgeons generally hate getting referrals for back pain, okay? Because if they don't have a spinal cord that's compressed, or they don't have a nerve root that's compressed, or they don't have overt structural instability that I can realign and stabilise with bone graft or pedicle screws or artificial discs, it's not very exciting. And it's also almost like, okay, I'm just going to spend 30 minutes with you telling you that there's nothing I can do at the moment. Maybe in 5 years' time, there'll be some bigger problems structurally, and come back and see me in 5 years' time. Just go back and do what you've been doing, maladapting, lifestyle changes, keep going and doing the physical rehabilitation that you've been doing. But really, that's a bit of a cop-out, because we already know that that hasn't been helping. Like, they wouldn't be coming to see me. You wouldn't refer them to me if the hydrotherapy, the Pilates, the core strengthening, the exercising, the weight loss, if that was working, they wouldn't be coming to see me. Okay, so that kind of made me really start to think about back pain from a completely different perspective, and look into the way the industry as a whole has been managing back pain for the last sort of 50 odd years, really. So now, whenever someone asks me to talk about back pain, I'm very excited about it, because I'm very passionate about it now. So if I go off tangent, and pull me back into line. So Ree's given me a little bit of an intro. My surgical practice, City to Coast Neurosurgery, and then about 15 years ago, we developed a bit of a sidearm of the surgical practice, which is referred to as the Back Pain and Functional Movement Training Centre, and it runs out of Woolloongabba. And that's the topic of my talk, the title of my talk, What Causes Low Back Pain? We already started on this topic here with Adrian about causation, and the clinical model for pretty much everything we do is treating disease and causation in conjunction with symptoms. And after this talk, I think you may appreciate a little bit more clearly that when it comes to this condition of back pain, we are treating back pain. We are not treating a valid cause of back pain. And that is why it is becoming such an epidemic in our society and in modern industrialised societies, because we're not following this central tenet of medicine that requires us to treat symptoms in conjunction with causation. Every other condition in medicine, we do that.